Hi everyone, this is Doc Ina and welcome to my lecture on hyperprolactinemia, galactorrhea, and pituitary adenomas. To download my lecture deck, please go to my WordPress site, Docina o Bigayne. Main reference for this lecture is Comprehensive Gynecology 7th edition, Chapter 39, Hyperprolactinemia, Galactorrhea, and Pituitary Adenomas. So first, what is prolactin? Prolactin is a polypeptide hormone containing 198 amino acids and with a molecular weight of 22 kilodaltons. Prolactin is synthesized and stored in the pituitary gland in chromophobe cells called lactotrophs, which are located mainly in the lateral areas of the gland. The major stimulating factor is thyroid-stimulating hormone, and the major inhibiting factor is dopamine, which has been suggested to be a prolactin inhibiting factor, or a PIF. Estrogen also improves prolactin secretion by enhancing the effects of TRH and inhibiting the effects of dopamine. The principal receptor with which dopamine interacts is D2, which is the target of various dopamine agonists used in the treatment of hyperprolactinemia. Prolactin is also synthesized in decidualized stroma of endometrial tissue, and from these tissues, prolactin is secreted into the circulation and, in the event of pregnancy, into the amniotic fluid. The control of decidual prolactin is different from that of the pituitary and does not respond to dopamine. Prolactin is normally present in measurable amounts in serum, with mean levels of approximately 8 nanograms per ml in adult women. It circulates in an unbound form, has a 20-minute half-life, and is cleared by the liver and the kidney. The main function of prolactin is to stimulate the growth of mammary tissue, as well as to produce and secrete milk into the alveoli. It has mammogenic and lactogenic functions. Serotonin and thyrotropin-releasing factors stimulate prolactin release. The rise in prolactin levels during sleep appears to be controlled by serotonin. Prolactin is secreted episodically and serum levels fluctuate throughout the day and throughout the menstrual cycle, with peak levels occurring at mid-cycle. Estrogen stimulates prolactin production and release. Prolactin levels increase in females at the time of puberty, and there is a slight decline in levels after menopause. During pregnancy, as estrogen levels increase, there is a concomitant hypertrophy and hyperplasia of the lactotrophs. The maternal increase in prolactin levels occurs soon after implantation, concomitant with the increase in circulating estrogen, and this may reach approximately 200 nanograms per ml in the third trimester. The rise is directly related to the increase in circulating levels of estrogen. Despite the elevated prolactin levels during pregnancy, lactation does not occur because estrogen inhibits the action of prolactin on the breast, most likely blocking prolactin's interaction with its receptor. A day or two following delivery of the placenta, estrogen and prolactin levels decline rapidly and lactation is initiated. Prolactin levels reach basal levels in non-nursing women in 2 to 3 weeks. Although basal levels of circulating prolactin decline to the non-pregnant range approximately 6 months after parturition in nursing women, following each act of suckling, prolactin levels increase markedly and stimulate milk production for the next feeding. Nipple and breast stimulation also increase prolactin levels in the non-pregnant female as does trauma to the chest wall, exercise, sleep, and stress. Prolactin levels normally rise following ingestion of the midday meal, and prolactin levels normally fluctuate throughout the day with maximal levels observed during the night while asleep and a smaller increase occurring in the early afternoon. The optimal time to obtain a blood sample for assay to diagnose hyperprolactinemia is in the fasting state and ideally during the mid-morning hours. When the amount measured in the circulation in the non-pregnant woman exceeds a certain level, usually 20 to 25 nanograms per ml, the condition is called hyperprolactinemia. Increases in prolactin levels above the normal range can occur without a pathologic condition if the serum sample is drawn from a woman who has recently awakened, has exercised, or has had recent breast stimulation, such as breast palpation, during a physical exam. Hyperprolactinemia can produce disorders of gonadotropin sex steroid function, resulting in menstrual cycle derangement and anovulation, as well as inappropriate lactation. The mechanism whereby elevated prolactin levels interfere with the gonadotropin release appears to be related to abnormal gonadotropin-releasing hormone release. Women with hyperprolactinemia have abnormalities in the frequency and amplitude of LH pulsations, with a normal or increased gonadotropin response following GnRH infusion. This abnormality of GnRH cyclicity thus inhibits gonadotropin release but not its synthesis. The reason for this abnormal secretion of GnRH is an inhibitory effect of dopamine and opioid peptides at the level of the hypothalamus. Elevated prolactin levels have been shown to interfere with the positive estrogen effect on mid-cycle LH release. It has also been shown that elevated levels of prolactin directly inhibit basal and gonadotropin-stimulated ovarian secretion of estradiol and progesterone. However, this mechanism is probably not the primary cause of anovulation because women with hyperprolactinemia can have ovulation induced with various agents, including pulsatile GnRH. The clinician should measure serum prolactin levels in all women with galactorrhea, as well as those with oligomenorrhea and amenorrhea not explained by any other reason such as ovarian failure. Hyperprolactinemia has been reported to be present in 15% to 20% of women who present with menstrual disturbances. Now, what are the special cases in the measurement of prolactin? Because of possible aggregation of molecular forms of prolactin when levels are high, if a tumor such as an adenoma is suspected and values of prolactin are only mildly elevated, the test should be repeated in a diluted sample. And this has been called the hook effect and is explained by high endogenous levels of prolactin binding up all the assay antibody, leaving an inadequate quantity for the assay. Prolactin levels may be elevated in a woman who is normal clinically. This is due to clumping of glycosylated prolactin with immunoglobulin and can be corrected by gel electrophoresis or merely by adding polyethylene glycol to the serum, which precipitates the abnormal forms. So what is galactorrhea? Galactorrhea is defined as a non-purpural secretion of watery or milky fluid from the breast that contains neither pus nor blood. The fluid may appear spontaneously or after palpation. To determine whether galactorrhea is present, the clinician should palpate the breast, moving from the periphery toward the nipple in an attempt to express any secretion. Diagnosis of galactorrhea can be confirmed by observing multiple fat droplets in the fluid when examined under low-power magnification. Unless there has been continued breast stimulation after a pregnancy, the presence of galactorrhea serves as a biologic indicator that the prolactin level is abnormally elevated. So here are the causes of hyperprolactinemia. Pathologic causes of hyperprolactinemia, in addition to a prolactin-secreting pituitary adenoma, or what we call a prolactinoma, and other pituitary tumors that produce acromegaly and Cushing's disease include hypothalamic disease, various pharmacologic agents, hypothyroidism, chronic renal disease, or any chronic type of breast nerve stimulation such as may occur with thoracic operation, herpes zoster, or chest trauma. And here are the pharmacologic agents that affect prolactin concentrations. One of the most frequent causes of galactorrhea and hyperprolactinemia is the ingestion of pharmacologic agents, particularly tranquilizers, narcotics, and antihypertensive agents such as what we have seen in the box or in the list prior to this slide. So of the tranquilizers, the phenothiazines and diazepam can produce hyperprolactinemia by depleting the hypothalamic circulation of dopamine or by blocking its binding sites and thus decreasing dopamine action. Tricyclic antidepressants block dopamine uptake and propranolol, haloperidol, phentolamine, and cyproheptadine block hypothalamic dopamine receptors. Antihypertensive agent reserpine depletes catecholamines and methyl dopa blocks the conversion of tyrosine to dihydroxyphenylalanine. Ingestion of oral contraceptive steroids can also mildly increase prolactin levels, with a greater incidence of hyperprolactinemia occurring with older higher estrogen formulations. And nevertheless, galactorrhea does not usually occur during oral contraceptive ingestion because the exogenous estrogen blocks the binding of prolactin to its receptors. Women who develop galactorrhea, while any of the drugs listed in the box that we showed you a few slides back, should ideally continue the medication, and the prolactin level should be measured 1 month thereafter to determine if the level has returned to normal. Now, if the medication cannot be discontinued, the prolactin level should be measured, and if elevated above 100 nanograms per ml, imaging of the sella turcica should be performed to determine whether a macroadenoma is present. Primary hypothyroidism can also produce hyperprolactinemia and galactorrhea because of decreased negative feedback of thyroxine on the hypothalamic pituitary axis. The resulting increase in TRH or thyrotropin stimulates prolactin secretion and thyroid-stimulating hormone secretion from the pituitary. Approximately 3% to 5% of individuals with hyperprolactinemia have hypothyroidism. Therefore, TSH, the most sensitive indicator of hypothyroidism, should be measured in all individuals with hyperprolactinemia. If the TSH level is elevated, triiodothyronine or T3 and T4 should be measured to confirm the diagnosis of primary hypothyroidism because a TSH secreting pituitary adenoma will occasionally be present. Treatment with appropriate thyroid replacement usually returns the TSH and prolactin levels to normal within a short time. Hyperprolactinemia can occur in those with abnormal renal disease resulting from decreased metabolic clearance and increased production rate. Mild hyperprolactinemia, that's about 30 to 50 nanograms per ml, may occur in women with polycystic ovary syndrome, and this occurs in up to 30% of women and may be related to the chronic state of unopposed estrogen stimulation. How about CNS disorders? Diseases of the hypothalamus that produce alterations in the normal portal circulation of dopamine can result in hyperprolactinemia, and this includes craniopharyngioma, which is the most common, and infiltration of the hypothalamus by sarcoidosis, histiocytosis, leukemia, or carcinoma. These tumors arise from remnants of the Rathke's pouch along the pituitary stalk. These are most frequently diagnosed during the second and third decades of life and usually result in impairment of secretion of several pituitary hormones. How about pituitary causes? This involves various types of pituitary tumors, lactotroph, hyperplasia, and the empty sella syndrome. As many as 80% of all pituitary adenomas secrete prolactin. The most common pituitary tumor associated with hyperprolactinemia is the prolactinoma, arbitrarily defined as a microadenoma if its diameter is less than 1 cm and macroadenoma if it's larger than 1 cm. Functional hyperprolactinemia is the term used for the clinical diagnosis of cases of elevated prolactin levels without imaging of an adenoma. Primary empty cell syndrome describes a clinical situation in which an intracellular extension of the subarachnoid space results in compression of the pituitary gland and an enlarged sella turcica. This is believed to result from a congenital or acquired defect in the sella diaphragm that allows the subarachnoid membrane to herniate into the sella turcica. How about prolactinomas? More than 10% of those in the general population have an undiagnosed prolactinoma, and there is an approximate positive correlation between the size of the adenoma and the prolactin levels. Majority of the prolactinomas in women are microadenomas or less than 1 centimeter in size. Now, it is believed that adenomas arise from single cell mutations with clonal proliferation occurring subsequently. It is also important to note that prolactinomas may also secrete other hormones, with the growth hormone or GH being the most common. Long-term studies have demonstrated that many of these tumors regress spontaneously. Natural progression from micro to macroadenoma has been estimated to be less than 7%. Now let's discuss the diagnostic studies. So imaging studies. So the current recommended techniques are to obtain a CT scan with intravenous contrast or an MRI with gadolinium enhancement. MRI provides better soft tissue definition without radiation, and the CT scan is principally beneficial for bony structural abnormalities. MRI provides 1 millimeter resolution and thus should be able to detect all microadenomas. It is currently the recommended imaging study to obtain. It is recommended that prolactin levels be measured in all women with galactorrhea, oligomenorrhea, or amenorrhea who do not have an elevated FSH levels. Prolactin is also frequently measured in the workup of infertility. If the prolactin is elevated, a TSH assay should be performed to rule out the presence of primary hypothyroidism. If the TSH level is elevated, T3 and T4 should be measured to rule out the rare possibility of a TSH secreting pituitary adenoma. If the TSH level is elevated and hypothyroidism is present, appropriate thyroid replacement should begin and the prolactin level will usually return to normal. If the TSH level is normal and the woman has a normal prolactin level with galactorrhea, no further tests are necessary if she has regular menses. If prolactin levels are elevated and the TSH level is normal, an MRI or a CT scan should be obtained. Of course, as we already mentioned, MRI is the preferable diagnostic method. And these are done to detect a microadenoma or a macroadenoma. Macroadenomas are uncommon and rarely present with a prolactin level that's less than 100 nanograms per ml. If the prolactin level is more than 100 nanograms per ml or the woman complains of headaches or visual changes, then the likelihood of a tumor extending beyond the sella turcica is increased. Microadenomas are a common cause of hyperprolactinemia and remain stable in most cases. Neither pregnancy, intake of oral contraceptives, or hormone therapy stimulates the growth of these small tumors or microadenoma. Therapy is unnecessary unless ovulation induction is desired or hypoestrogenism is present. Routine visual field testing and measurements of ACTH, GH, and thyroid function are not necessary unless warranted clinically, and these evaluations, particularly visual field testing, should be performed in women with macroadenomas because suprasellar extension of the tumor may exert pressure on the optic chiasm, resulting in bitemporal visual field defects and interference with vision. The size of these tumors may also affect other aspects of pituitary function. With the macroadenoma, dynamic tests of pituitary function should be performed. Now, lastly, we discuss the treatment. So, for cases of hyperprolactinemia, can we do expectant treatment or is there room for expectant treatment? The answer is yes. And these are usually for women with radiologic evidence of a microadenoma or functional hyperprolactinemia who do not wish to conceive, and they may be followed without treatment by measuring prolactin levels once annually. However, if estrogen is deficient, low estrogen levels in combination with hyperprolactinemia has been shown to be associated with the early onset of osteoporosis. So exogenous estrogen should be administered. Hormonal therapy, as is used for postmenopausal women, or oral contraceptives may be used. Oral contraception used in a group of women with hyperprolactinemia with microadenoma do not alter the size of the adenoma. Because side effects and cost are less and compliance is better with exogenous estrogen than with dopamine agonist therapy, it is not necessary to use the latter unless ovulation and pregnancy are desired. Those with hyperprolactinemia, with or without microadenoma, who have adequate estrogen levels and who do not wish to conceive should be treated with periodic progesterone withdrawal. Like, for example, give them medroxyprogesterone acetate 5 to 10 milligrams per day for 10 days each month, or with combination oral contraceptives to prevent endometrial hyperplasia. So, who are those patients that we can initiate medical treatment? The initial treatment for women with macroadenoma as well as for those women with hyperprolactinemia who are anovulatory and wish to conceive should be administration of a dopamine receptor agonist. And this come in the form of Cabergoline, Bromocriptine, and Pergolide. Pergolide is currently not available. So here in our country, the Philippines, bromocriptine is the only available medical treatment. So what is bromocriptine? Bromocriptine is a semisynthetic ergoid alkaloid that was developed in 1967 to inhibit prolactin secretion. It directly stimulates dopamine 2 receptors, and as a dopamine receptor agonist, it inhibits prolactin secretion in vitro and in vivo. After ingestion, bromocriptine is rapidly absorbed, with blood levels reaching a peak of 1 to 3 hours later. Serum prolactin levels remain depressed for approximately 14 hours after ingestion of a single dose, after which time the drug is not detectable in the circulation. And this is usually given at least twice daily, with initial therapy being started at half of the 2.5 mg tablet to minimize its side effects. The most frequent side effects are orthostatic hypotension, which may manifest as fainting and dizziness, as well as nausea and vomiting. Now, to minimize these symptoms, the initial dose should be taken in bed or at bedtime and with food at night. Less frequent adverse symptoms include headache, nasal congestion, fatigue, constipation, and diarrhea. To reduce the adverse symptoms, the dose should be gradually increased every 1 to 2 weeks until prolactin levels fall to normal levels. And then they may also be administered vaginally or even rectally. The greatest decrease in prolactin occurs in the first 2 to 4 weeks. And bromocriptine is preferred over cabergoline for pregnant patients. Next is Cabergoline. So this is a long-acting dopamine receptor agonist and is currently preferred over bromocriptine for primary therapy because of greater efficacy and fewer side effects. This drug directly inhibits pituitary lactotrophs, thereby decreasing prolactin secretion. It is given orally in doses of 0.25 to 1 mg twice weekly. So the initial dose is half a 0.5 mg tablet twice a week. Peak plasma levels occur in 2 to 3 hours, and the drug has a half-life of 65 hours. That's why it can be given twice a week. Its slow elimination and long half-life produce a prolonged prolactin lowering effect. A potential concern, though, with cabergoline and pergolide is the development of cardiac valvular lesions, and this has only been observed with large doses as used for Parkinson's disease and has not been reported with lower doses, thankfully. It has been suggested that cardiac ultrasound be performed every 2 years in patients on chronic therapy of cabergoline at doses of less than 2 milligrams per week. So for the last part in our treatment section, we discuss some operative approaches for prolactinoma. So we have the transsphenoidal microsurgical resection of prolactinoma, which has been widely used for therapy, but the mortality is of less than 0.5%. The risk of temporary post-op diabetes insipidus is about 10% to 40%, but the risk of permanent diabetes insipidus and iatrogenic hypopituitarism is less than 2%. The initial cure rate with normalization of prolactin levels and return of ovulation is relatively high for microadenomas, but less so with macroadenomas. The initial cure rate is related to the pretreatment prolactin levels. Those tumors with prolactin levels less than 100 nanograms per ml have an excellent prognosis, and those with levels higher than 200 nanograms per ml have a poorer prognosis. Because of the good results with medical therapy, surgery is recommended only for women with macroadenomas who fail to respond to medical therapy or have poor compliance with medical therapy. It is best to reduce the size of macroadenoma maximally with bromocriptine first before surgical removal of these extracellular tumors. So how about radiation therapy for macroadenomas? Now, external radiation with cobalt, proton beam, or heavy particle therapy and brachytherapy with yttrium-90 rods implanted in the pituitary have all been used to treat macroadenomas but are not the primary mode of treatment. The current method of choice is probably the gamma knife and linear accelerator. Damage to normal pituitary tissue may occur, leading to abnormal anterior pituitary function and diabetes insipidus. Radiation therapy should be used only as adjunctive management following incomplete operative removal of large tumors. That's it for my lecture. Thank you for watching this video, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you!